Welcome back to Antibiotic Answers. Today's topic is Helicobacter pylori, more commonly known as H. pylori. H. pylori is a bacteria that colonizes the stomach lining and is strongly linked to peptic ulcer disease and gastric cancer. The United States, the overall prevalence is less than 20% among non-Hispanic white adults, but this varies by region, with the Midwest having some of the lowest rates. Treatment success also varies geographically. Recent studies found eradication rates to be over 80% in the Northeast, compared to about 75% in the Midwest. For patients who are treatment naive, the gold standard recommended by the American College of Gastroenterology is now bismuth quadruple therapy for 14 days. This includes a proton pump inhibitor, tetracycline, bismuth, and metronidazole. Clarithromycin-based triple therapy should generally be avoided now, unless clarithromycin resistance is known to be very low in that community. This is because of rising resistance, which has significantly lowered success rates. For patients who have already been treated, salvage regimens should be chosen based on prior therapy and, whenever possible, guided by susceptibility testing. It's important to always confirm eradication after treatment. Testing should be done at least 4 weeks after finishing therapy, and the preferred methods are urea breath testing or stool antigen testing. Serology should not be used because it can't tell the difference between past and current infection. To get the most accurate results, patients should stop proton pump inhibitors for at least 2 weeks before testing and avoid bismuth or antibiotics for at least 4 weeks. This ensures that the bacteria isn't temporarily suppressed and avoids false negatives. From a stewardship perspective, clarithromycin and levofloxacin should not be used empirically in treatment-naive patients. Susceptibility testing, which is becoming more widely available, should guide therapy whenever possible. The approach has shifted away from trial and error prescribing towards a stewardship-based treatment model. That means not reusing regimens that have already been failed and confirming eradication to prevent ongoing resistance and transmission. Recent literature also emphasizes the need to integrate antimicrobial stewardship into H. pylori management. This will help reduce unnecessary antibiotic exposure and protect the effectiveness of regimens moving forward. In summary, H. pylori is a major cause of ulcers and gastric cancer. Bismuth quadruple therapy is the gold standard first-line regimen in most cases. Eradication should always be confirmed at least 4 weeks after treatment, and stewardship plays a central role in selecting regimens, avoiding resistance, and ensuring long-term success. Thank you for listening to this Antibiotic Answers session. For any questions, please reach out to Dr. Emily Perry, the CAP Center's antimicrobial stewardship pharmacist.